My presentation is on the epidemiology of community-acquired MRSA. So what is MRSA? MRSA stands for methicillin-resistant Staphylococcus aureus. It is a type of bacteria that causes staph infections that are difficult to treat because of resistance to some antibiotics. Staph infections, such as those caused by MRSA, can spread into hospitals, other healthcare facilities, and into the community where people live, work, and go to school. MRSA in the community usually causes skin infections, but can cause pneumonia in some cases. And to the left is a picture of MRSA bacteria under a microscope from the CDC's website. There are no statistics on the prevalence of community-acquired MRSA at the city or state level. Also, the morbidity and mortality rates of community-acquired MRSA are not reported. According to the CDC, approximately 33% of people carry Staph aureus bacteria in their nose, and about 2% of people carry MRSA. MRSA bloodstream infections in healthcare between 2005 and 2012 were 17.1% per year. However, prevalence of community-acquired MRSA can be difficult to distinguish from hospital-acquired MRSA. Community-acquired MRSA prevalence can be underestimated because individuals with healthcare-associated risk factors are not classified as community-acquired. Healthcare-associated risk factors include recent hospitalizations or surgery, dialysis, long-term care facility residence, and presence of indwelling catheter or percutaneous medical device. However, these individuals may have acquired MRSA infections of community origin and are not associated with their healthcare-associated risk factors. This is how community-acquired prevalence and rates can be underestimated. Also, community-acquired MRSA isolates can spread into hospitals. Therefore, it is difficult to distinguish epidemiology data from hospital-acquired and community-acquired MRSA. Natural history of community-acquired MRSA. An individual can have colonization of MRSA for months to years, which is asymptomatic in most people. Therefore, MRSA infections can develop in a different setting than where the colonization was acquired. Community-acquired MRSA causes infections of skin and soft tissue, such as abscesses, cellulitis, and impetigo. These infections are usually mild, but may be severe, resulting in hospitalization and death. Such severe infections include necrotizing fasciitis and necrotizing pneumonia. Patients are usually treated with incision drainage and oral antibiotics. Patients are treated outpatient and few require hospitalization. Decolonization of MRSA is not recommended because there is not enough data to establish efficacy. Diagnosing MRSA. MRSA is spread through contact. Reservoir can be human or environmental. The portal of entry for MRSA skin infection is usually through opening in skin or mucous membranes. The mode of transmission is direct or indirect contact. Diagnosis is based on history, risk factors, and physical exam. Diagnostics include single or multiple skin lesions with or without drainage. Purulent drainage can be sent for culture and sensitivity. Confirmation of MRSA infection include all the following criteria. Diagnosis must be made in the outpatient setting or within 48 hours of admission to the hospital. No history of MRSA colonization. No history of hospitalization, skilled nursing facility, hospice, dialysis, or surgery within the past year. And no permanent indwelling catheters or medical devices. Nurses' role in prevention, screening, and treatment. Prevention. Nurses should educate patients living in high-risk situations, such as those living with someone who has a MRSA infection. Nurses should also provide hand washing and cleaning education to those with skin and soft tissue injuries. Screening. Nurses should advocate for screening of high-risk patients, such as those living in nursing home and athletes. Treatment. Nurses need to follow contact precaution guidelines when treating MRSA patients to prevent spread to others. Nurses should educate patients with MRSA about how to prevent the spread to those they come in contact with hand washing techniques, environmental cleaning, and covering open wounds. Preventing the spread of MRSA will prevent further disability during convalescences. At-risk groups. Rates are highest among children and adolescents. People living in close quarters with colonized persons are 14 times more likely to be carriers. Other close quarter or overcrowded living spaces that pose a high risk include military installations, prisons, long-term care facilities, and daycare centers. Repeated skin tissue trauma are seen in athletes and military recruits, also carry high risk. Ethnic groups that have higher prevalence include Native Americans, Pacific Islanders, and African Americans. Consistently high prevalence is in the U.S., South America, Japan, and Southern Europe. Other high-risk groups include IV drug users, immunocompromised patients, and the homeless. Another at-risk group are people who are in contact with the healthcare system. High rates of infection are among those who have seen a physician in the past year and those who have used antibiotics. Global risk of issue. There is no vaccination for community-acquired MRSA. It has a high potential to become an endemic because of the high frequency of transmission by asymptomatic colonized individuals. Control measures to prevent an endemic include screening asymptomatic individuals. This is seen in acute care hospitals now. In hospitals, MRSA spread can be reduced with infection control measures such as isolation and personal protective equipment. Colonization rate in the U.S. is approximately 1 to 2%, while colonization in other countries can be as high as 50%. Travelers from the U.S. to other countries should be aware of the higher rate of colonization and should be careful to cover any opening in skin tissue. Travelers should be cautious of overcrowded areas, such as tourist destinations and airports. Anyone traveling from another country to the U.S. has the potential to carry MRSA on their skin or in their nares. MRSA is not routinely screened for outside the healthcare setting. Therefore, immigrants could carry MRSA into the U.S. with them and spread it within a community. Primary level of prevention. Educate well patients who are in close quarters with individuals who are colonized with MRSA to wash their hands often and shower regularly, especially after exercise. Also educate patients with open skin to keep cuts, scrapes, and wounds clean and covered until they heal. Patients should avoid sharing personal items like towels or razors. This education is useful for those living with individuals colonized with MRSA or for those coming in direct contact with those with MRSA, such as athletes and healthcare workers. A post-program evaluation strategy for this primary level of prevention will be to track the incidence of new cases of community-acquired MRSA. Most secondary prevention for community-acquired MRSA occurs in the hospital setting because there are no guidelines for routine screening in non-healthcare or outpatient settings. Screening for MRSA in hospital settings is becoming more common. However, screening for hospital-acquired MRSA colonization on admission to the hospital has not decreased rates of infection. Good hand hygiene, contact precautions such as gown and gloves, and environmental cleaning between patients reduces rates of MRSA infection. Post-program evaluation would be to compare rates of MRSA incidence from screening in hospitals over time. Tertiary level prevention. After successful treatment of MRSA infection, it may be beneficial to decolonize some patients. These patients include those with repeated MRSA infection despite good hand hygiene practices and those with close contact to other colonized individuals. Decolonization includes nasal mepronium twice daily for 5 to 10 days, mepronium and topical antiseptic solution for 5 to 14 days, or mepronium and dilute bleach bath 15 minutes twice daily for 3 months. However, evidence supporting this practice is limited. Even when eradication is initially successful, about half will test positive within a year. A post-program evaluation will be to reculture those who have been decolonized over a 5-year period. A good example of primary and tertiary level prevention comes from an outpatient clinic in Baltimore. They implemented a screening and cleaning procedure to prevent further infections and prevent reinfection in workers recovering from a MRSA infection. This procedure was implemented after 2 healthcare workers developed skin and soft tissue infections due to MRSA. First, the clinic swabbed clinic chairs, examination tables, keyboards, doorknobs, telephones, medical equipment, and healthcare workers' nares and hands. They found that 2 out of 128 workers had MRSA colonization on both their nares and their hands. They also found that 7 of 36 environmental cultures grew MRSA. Environmental sites contaminated include examination table, a computer keyboard, a pulse ox, and multiple patient chairs. These results were then reported to the Environmental Services Department. A thorough cleaning was done, and disinfection wipes were placed in each examination room. Repeat swabbing was negative for MRSA. This is a good example of how to prevent and control a MRSA outbreak in any healthcare setting. Government action. One objective of Healthy People 2020 is to prevent, reduce, and ultimately eliminate healthcare-associated infections. Healthy People 2020 does not directly address community-acquired MRSA. However, community-acquired can be brought into the hospital and create hospital-associated infections. The government created a forum on antibiotic stewardship to reduce the overall burden of antibiotic-resistant organisms like MRSA. They recommended that all acute care hospitals implement programs to improve antibiotic use and slow the development of antibiotic resistance. Although the Pennsylvania Department of Health does not directly address community-acquired MRSA, it does have established policies for hospital-acquired MRSA. Since 2008, they've required hospitals, acute care, long-term care, and inpatient rehabilitation centers to report MRSA events to the National Healthcare Safety Network. Other hospitals such as Critical Access, Children's, and Psychiatric Specialty Facilities may elect to report MRSA events but are not required. According to Healthy People 2020, invasive healthcare-associated MRSA infections have decreased since 2015. Baseline data collected in 2015 was set at 1.0 standardized infection ratio for infections per 100,000 population. The target for 2020 is 0.5. The standardized infection ratio for 2016 was 0.94, and for 2017 it was 0.84. Another study, however, reports that estimates of the incidence of MRSA infection vary depending on the population, type of infection, and the definitions and terminology used in reports. There is not current definitive evidence that MRSA infections in the U.S. are significantly decreasing. Discrepancies among reports exist and make it difficult to show evidence of reduction. Discrepancies are due to the inability to reconcile baseline data of different facilities. To properly track and trend of MRSA infections in the U.S., there needs to be a comprehensive tracking and monitoring system that is uniform to all types of healthcare facilities, not just acute care hospitals. Ethical considerations. This is a study from 2016, and its purpose was to reveal and interpret how acquiring community-acquired MRSA affects otherwise healthy patients' lived experiences of receiving care in their everyday life. The author used interviews with 12 patients, and they were recruited from a hospital database. They covered both genders, and patients under the age of 18 and patients with dementia were excluded from the study. The interviews were transcribed verbatim in text and analyzed over 3 phases. The study found that patients who acquired MRSA infection experienced a change in body image. They also report suffering from ignorance and frightened behavior from healthcare workers, social contacts, and bullying from colleagues. The findings also report that knowledgeable healthcare staff helps alleviate suffering and brings a peace of mind. This study is important because the thoughts and feelings of patients who experience MRSA infection are an important part of recovery. The study reported that knowledgeable staff alleviates suffering and brings peace of mind. Although MRSA infection is a physical disease, it is important to acknowledge the effect it can have on mental health of affected patients. The following 2 slides are the list of my references used throughout the presentation.